Good morning, everyone. Scleritis, coming directly to the presentation of infectious scleritis. Scleritis is a painful state of ocular inflammation which causes destruction, and the clinical features and etiology is such that it mimics the immune-mediated scleritis, and so it is very difficult to identify these cases. So the epidemiology in developing nations, what we have, slides are not moving. So in developing nations, we have seen that the incidence of infectious scleritis is higher, around 18 to 30%, and the most common cause is fungal, and it is identified in the younger male population. The mode of infection goes from exogenous to endogenous variety. The exogenous being most commonly the surgical trauma, post-surgery, or trauma from vegetative matter, or spread from adjacent ocular inflammation. And these cases have more greater severity of tissue damage. And the endogenous causes are systemic illness like tuberculosis, herpes, or syphilis, and these mimic more of immune-mediated variant. So there are various studies reported from India which show that surgery has been the most common cause and fungus and bacteria have been higher in the list. So I'll be presenting two cases. The first case is a 58 years old male farmer who complains of pain and redness since 7 months, and there was no history of trauma or surgery. He's a known case of diabetes, and he was diagnosed elsewhere as immune-mediated scleritis, and he was treated with topical and systemic steroids. So you can see in the pictures that there was a superinasal infiltrate around 5 into 5 millimeters there were exudates upon the iris, and there was a streak hypopion. We planned for a corneal scrapings, and we found budding yeast cells with pseudohyphae. Now, and in the last picture, you can see there was a nodular lesion which was there around 4 to 5 millimeters superior, and there was an area of thinning besides that lesion. So we decided on scleral wound exploration in this patient. And to our shocking, we found two foreign bodies which are there in the superior picture. And these are the pictures of the yeast hyphae. So we started the patient on antifungals, oral as well as systemic, and we obviously stopped the steroids, and the patient resolved very well. My second case is a patient who again complained of pain in the left eye for 3 months, again with no history of trauma and surgery. And she was also treated as immune-mediated scleritis. The patient was also on azathioprine for 3 months. And this patient, as you can see in the pictures, she came with diffuse involvement, diffuse congestion, and there was some area of nodular congestion on the nasal side. So we started the patient on oral NSAIDs and topical steroids, considering it to be immune meteorology. But after 2 weeks, when the patient presented to us, this was the picture. So there was a nodular area which was looking a little purulent. So we planned for scraping with scleral exploration, and we found GPC on the smear. So we treated the patient with antibiotics, and we can see that there was progression of the nodules, and there was migration of these nodules in various quadrants. And so we repeated the scleral biopsy, finding it to be nocardia. Then we treated the patient with amikacin and sulfamethoxazole and trimethoprene. After 3 weeks, we started the patient on prednisolone eye drops, and there was resolution in 5 months. So I'll skip this. At the end, I want to conclude that it is important to differentiate between immune-mediated and infectious. So infectious always presents as immune-mediated, and most of the times if the patient doesn't give any history of trauma or there is not an obvious sign of infection or a corneal lesion, so we should be very careful and meticulous screening, and repeated biopsies might be required to come to a diagnosis. Thank you. Yes.
So would scleral thinning or scleromalacia still you would go ahead with biopsy in those patients?
Yes.
Is it a sign of previous biopsy?
That was a sign of previous biopsy. So the patient might have undergone biopsies elsewhere. We don't have the exact literature of that patient. Even the second patient underwent biopsy elsewhere, but still did not reveal any organisms. So we managed the patient as immune mediated in the second attempt. But both these biopsies, there can be scleral thinning, and you have to be very careful. And AMG can be used as one of the options. In
So, I
second,
mean, in your study, in this case series, it would be good to have a clear-cut, picture as to in which cases to suspect infection, in which cases not to, because doing a biopsy in an inflammatory or an immune-mediated scleritis may be
yes,
counterproductive.
yes.
Yeah.
Also, the disease itself can produce thinning. The scleral or scleritis can produce or will produce thinning of sclera over a period of time.
Yes.
Thank you.